All right. So I guess I'll kick it off, okay?
Perfect.
Hello and welcome to another episode of the Ideals of Medicine interview series. My name's Matt, and I am glad to be joined in conversation today with Umer Warris and Dr. Doug McMullin. I'm currently a family medicine resident at Natividad Medical Center in Salinas, California. And Umer and I co-founded this organization, Ideals of Medicine, in order to reclaim the true narrative of our profession. When we take the physician's oath, we promise to serve our patients first and foremost, with the understanding that there are certain ideals that we must strive to live by as medical professionals. Unfortunately, our medical institutions and health policies may not always reflect these ideals. Thankfully, there are medical leaders who exemplify and fight for these ideals, and today we welcome the opportunity to learn from one of them. We are lucky enough to have an exemplar here with us today. Umer, would you go ahead and introduce Dr. McMullin?
Thank you so much, Matt. Hello, everybody. My name is Umer Warris, and I am a family medicine resident here in Redding, California at the Mercy Medical Center. And it is truly an honor to introduce one of my teachers and mentors, Dr. McMullin, for this installment of the Ideals of Medicine interview series. Dr. McMullin is a family physician here in Redding for the past 25 years. He studied chemistry at the Brigham Young University prior to attending the Chicago Medical School. He joined the staff of the Shasta Community Health Center, SCHC in short, in 2013, and was recently appointed as the Chief Medical Officer for the organization. He previously served as the Associate Program Director of the Family Medicine Residency Program at SCHC. Shasta Community Health Center is a federally qualified health center. And for those that don't know, FQHCs are clinics that provide comprehensive primary care to all, regardless of ability to pay or insurance status, particularly in underserved areas. Recently, SCHC was ranked as among the top 1% of FQHCs in the country by the Health Resources and Services Administration, which is an agency of the federal government that ranks community health centers and gives them that distinction. This was quite the honor for SCHC. Of particular note, Dr. McMullin, during his time at Shasta Community Health Center, developed a curriculum for homeless outreach involving students and residents, and has been an advocate for housing and healthcare for the homeless. He is also heavily involved in the medically assisted therapy program, or the MAT program at the clinic, treating addiction in many forms. Dr. McMullin and his wife are proud parents of 6 children and include hiking, gardening, and swimming as among their favorite leisure activities in the beautiful nature-esque Redding area. As you can see from this introduction, Dr. McMullin in his time at Shasta Community has come to exemplify many of the ideals that we value on our Ideals of Medicine interview series. And so, Dr. McMullin, we are highly honored to have you on.
Thank you. That's a very generous introduction. I appreciate that.
Of course. Dr. McMullin, as an icebreaker, we wanted to begin by asking, is there any book, movie, documentary you have come across recently that inspired you and you would recommend to others as well?
That's a great question. I like to dabble with Sir William Osler. So he's got a book. It just comes to the top. I can't claim to have read this thoroughly, but called Aequanimitas, with other addresses by Sir William Osler. And he's kind of a historical hero of mine in medicine. for his equanimity and contributions.
Cool.
So
Amazing, amazing. I feel like many of his writings, those essays, and believe it or not, I have the same book on my bookshelf here as well. But I feel like worth revisiting, and we actually have his picture as the icon picture for the ideals of medicine.
oh, perfect. I
Yes,
didn't know
yes.
that. Yeah, good.
Fits quite well. And Dr. McMullin, to discuss a little bit more about your personal journey, particularly in medicine, what drew you to a career in medicine, particularly family medicine? And have there been any mentors or role models whom you have learned from?
Absolutely. I think we all get those as we move along, and that's what gives us our thoughts and our directions about what we want to do. I was, through high school, either going to be a doctor or a teacher, and to me, they were kind of similar. And that's that you had a knowledge base in some subject, and then you basically share it or teach it every day, and that's what a physician should be. So docere, the Latin or Greek, whichever one it is, root of that word is to teach, like doctrine. And but I loved the subject matter in medicine. I loved physiology. I loved anatomy. I loved the pathology. That really drew me naturally since I was probably 16 or so. I had a physiology teacher in high school that was just fantastic, and we watched, movies of heart surgery and baby deliveries, and we dissected pigs and all sorts of things, and it was a fantastic exposure. He really went above and beyond to give us that experience. And I didn't settle on family medicine until I was probably a fourth year student in medical school. Trying to look at the different ones. And then one day I read a prospectus from a family medicine program and just realized that you got to have the whole pie in family medicine. You don't go down 3 inches. You don't go deep on it, but you have the whole pie. You have some orthopedics, you have some OB, you have GYN, you have peds and internal medicine. And I think all of us get attracted to parts of medicine for different reasons. Some are more driven to be really an expert at one subject matter. And of course, that would be a specialist, a rheumatologist or plastic surgeon and things like that specialize in one thing. But I wasn't satisfied, like on the ortho rotation, they wouldn't touch diabetes. And on the neuro rotation, they wouldn't touch athlete's foot. We had to do a dermatology referral that would take 6 weeks to get this poor guy's foot better. It just made no sense to be that segmented to me. And so that's why I came towards family medicine. Really, that was in the beginning, the subject matter, the topics, the connectivity and ability. I think all physicians connect with their patients if they wanted to. I think in family medicine, we do it a little bit more naturally, and by the nature of our calling in medicine. But so just some thoughts on that. And then I entered a practice that was very busy for many years, and it was fairly financially driven, and that's okay. Everyone's going to need to, pay their bills and keep the lights on. But after a while, it got to be a little rote and a little, I began to need to develop other hobbies of interests, because that wasn't really so much fun anymore.
Interesting that you bring that up. Dr. McMullin, I wanted to get your input on the ongoing epidemic of burnout in medicine, and particularly in primary care. Many people describe ongoing challenges with clicking in the EMR, less time being allowed for patient interaction, and the systemic failures as well, such as the fragmentation you've mentioned between different health systems, different health specialties, or just in general, too little funding for public health. And as some possible reasons for the epidemic of burnout in medicine. And so just given all of this, curious to know, how have you been able to maintain meaning and joy in medicine and in primary care over your career?
I think for all of us, it waxes and wanes. There's some studies that I read a while ago. One was pertinent to residents, and it said that medical students and residents become less idealistic as they progress in training, and they become more cynical as they progress in training. In particular, that article was with reference to homeless people, that as students and residents moved along in their school and residency, they became less compassionate towards homeless people, which was a really interesting way to look at it. I think that's not specific to homeless people. That's specific, that's compassion and cynicism in general. So you have to ask yourself, what's driving people to lean that way? So the natural man would lean that way and become cynical and suspicious and less. And I suppose it's because of busyness. I suppose it's because of encountering patients who might take advantage of you, or might have other agendas or ulterior motives. But I think it's really just something that we all have to. If we're going to avoid burnout, we really need to fight against that. There's a reason you went into medicine. If you can keep that candle lit, I think you'll be okay. If you get very very occupied by the financial side of your life, and that becomes what you're thinking of every day, which is a normal evolution in many cases, then that's prime for burnout. So in my private practice, that was primarily a suburban setting. I had very nice patients, enjoyed them immensely. Very nice people, mostly motivated, fairly sophisticated, mostly motivated for to be healthy. But for me, we had meetings, we had business meetings. We had to watch our overhead. We had to watch our, how much we're spending. Are we going to buy immunizations this year? How's that going to impact our income flow, our cash flow? There were months where you wouldn't get a paycheck because of the cash flow problems. And so it became, the daily issue was to make sure you saw 30 patients, because that's what you needed to do in order to make an income that was average for primary care. And so then when you're thinking about that all day, you got to get your 20 in the morning and your 10 in the afternoon. When you're thinking that way, you can do that for a while, but that's not why you went into this. Probably you didn't go into medicine to get rich or to just, you probably went into it because it's a comfortable living. But if that's what becomes the focus of your day in and day out, that's prime burnout to me, because there's nothing that fills your tank there. If anything glitches in your cash flow, then you're disappointed. If it doesn't go quite right, then you feel negative or bad. And patients become a burden. And this patient seeing me again when I just saw her 2 weeks ago is a burden. Why do I need to see her again? And I'm complaining and I'm negative. And that's the trail to hating your practice, I think. You really need to watch the money thing and not let it become central. It's got to be a part. You have loans to pay back. You need to and should be able to, support your family and get a house and a car. But it doesn't have to be a big giant house, and it doesn't have to be a Jaguar to drive. But you'll see people who make a lot of money in medicine, and there's a few of them who keep the heart of medicine up front. but very often, once they get into their practice, once they start focusing on the money, that's where I see my colleagues, splitting up with their marriages. That's when they start to be sad and depressed and have to go travel to crazy places on their own, or get something that's exciting for them, something else. And that's unfortunate. That's really too bad. So that's the sad scenario for many. But
Dr. McMullin, very, very insightful, and I feel like you speak with years of experience when you shared that insight. And both Matt and I are currently in the second years of our residency. We hear you, and Matt and I often texting one another, hey, I'm having a difficult time. I'm worried that I'm losing my idealism, I'm losing my compassion. And so we relate to the point you had of becoming more cynical, worried that we're becoming more cynical, and then also relate to your point about feeling that how will the finances add up? Will they add up with the burden of student loans, so on and so forth? And that knowingly or unknowingly then becoming the predominant focus for the career. And I feel you touched upon that very well. So my question on that will be, given your leadership in running a residency program, what have you implemented? What practices, what systemic guardrails have you implemented to protect residents and their idealism and their mission, and keeping the heart of medicine up front? And that's probably not just for residents, but now as a chief medical officers for the rest of the clinic that you may be doing.
Yeah, those are good points. And informally, those are wellness programs that we try to implement. Some wellness programs just give us more to do, right? So we have an evening activity or a weekend activity, there's more to do. That's not necessarily wellness. But I think there's a couple of thoughts as you go along in life that I would hope that my residents would do. One is to keep some kind of balance. In all your busyness, make yourself go exercise. Do something, whether it's I know I don't know if it's in Matt's program, but one colleague I have, he swims in the bay. That's a big thing, right? Make yourself go exercise. Make yourself spend time with your family. Cut out and delegate specific time for those things. Just like it took a specific time to learn your profession. If you want to hang on to anything that you treasure, you need to cut out time for it. You need to have a specific time. Time is the currency. So that there's a balance that you've got to keep. One of our residents, she started taking violin lessons when she was a second-year resident. That's ambitious, but it gave her that little break. Downtime with nothing in your head isn't necessarily restful, but something else that's entirely different can be very rejuvenating. I think you should try to look at your day with gratitude. So each, in the day, write down 3 things you're grateful for, you're thankful for. I'm in a good program. I live in a place where I can be healthy. Lots of things, lots of gratitude-oriented things that we really tend to focus on the negatives because we're problem solvers. So let's go fix that, and we're thinking about the negatives. But it's good to have some gratitude in your daily walk. Right. I think you need to make an occasional change in your practice down the road. 5 years into it, you may decide, I'm going to really change what I'm doing. I'm going to go do a locum in New Zealand or Africa, or I'm going to, for me, it was switching from private practice to an FQHC. very, very rejuvenating. Big change in the setting. It was very exciting and fun. And I know I'm going on and on here, but another piece of it is to find your niche in the wideness of general practice and family. Find something that you really may like to focus on a little bit in that big arena, that big piece of the pie where you can go just a little deeper for your own professional edification, your own. For me, very surprising, I hated psychiatry in medical school. I told my wife I will never go near psychiatry again. It was a lockup ward in North Chicago. It was, your life was in jeopardy when you went in there. It was very interesting, but I really have come to enjoy psychiatry and behavioral components of our practice, and I've made extra efforts to learn more about that and to become better. And to, when you find niches, then you can become resources for your colleagues. Whatever it is, we've got one colleague, it's his OB experience is his niche. For another colleague, it's their medicine experience or their pediatrics. Those are just some thoughts. You need enough money to live, but more money won't make you more happy. Too little money is a displeaser, but more money is not a greater pleaser. You'll never really have enough. If you get my drift, I mean, we never have enough. We always will want more, right? But you need enough, but more doesn't make us more happy. But those are some burnout thoughts. I have one colleague, I feel really bad, he's retiring, and word was he is fed up with medicine and never wants to touch it again. And I think that's really tragic, because he's very smart, very brilliant at it. It's just the finances have just driven him to go there. I think he needs a change. He needs to go somewhere here and there. You need to medically help someone often that can never repay you. And if you look at your practice, there should be people that you maybe take care of, for whom you will never get paid. And if you always do that, I think that's an important part of not burning out.
Wonderful.
Go for it.
No, that's very, very much needed advice, particularly as both, once again, Matt and I are going through this training process. And Dr. McMullin, you touched upon the residency training component, addressing burnout within that, and tips for that. I thought I would take a little bit of a broader look and talk about FQHCs. And as mentioned before, FQHCs provide comprehensive primary care, regardless of ability to pay and insurance status. And hence, it can be said that they are among the few bastions of the ideals of medicine, which include justice, equity, public service. And as mentioned prior, Shasta Community Health Center ranks among the first or among the top 1% of FQHCs fulfilling that mission. What allowed Shasta Community to earn that distinction? And then I had a follow-up question after that as well.
So the health center I work in, Shasta Community Health Center, it's really been a life-changing experience for me to go there. And so about 8 or 9 years ago, I went to that organization at the time because they were developing a family practice residency program, and I'd wanted to teach. So I went there for the teaching. That health center is a happy place. It's a happy place to work. It's very well organized and very well run. I think because their CEO, his name is Dean Germano, has really embarked his careers to develop a health center, an FQHC, and he is mission driven. we do a lot of things that we don't get paid for. We do a lot of things that that we pay to do. We have to be judicious about that because you've got to run in the black and you've got to pay the light bill. But if you turn down every project simply because it won't be profitable, you're following the dollar only, and that leaves us kind of hollow and empty. We might have financial success. We might, every mission needs a margin, but along the way, they have been, and he has been very prudent financially. So it's given them enough resources to be able to do some extra things that don't completely pay for themselves. I think your hospital, Umer, has done this through the years. Mercy Medical Center has sponsored the maternity clinic, and they sponsored that maternity center for high risk and teenage pregnancies for years. And I'm sure it has run at a loss if you look at it in an isolated fashion. But the sisters there were quite intent upon keeping that going. It's a big service to the community. It's an important part. And as I watched them, I was impressed that they kept that piece going for as long as they did. It's now our privilege as a health center to have that maternity center in our umbrella. And but I think FQHCs in general are designed, as you say, to treat everyone who walks in the door, regardless of ability to pay. If in my practice, my professional practice, whether I'm a dentist or a doctor, if I equate my services with remuneration constantly and only, it's very selfish, and it's very that's a high road to burnout. If I equate my ability, my professional ability to help and treat more to the importance of individuals and their health and their happiness, that's where you want to be. And so I think you can do this in a private practice too. I think you can do it at Kaiser. I think you can do it anywhere if you focus on that and you go there each day to help your patients. FQHC just leans that way naturally. Like most of our patients are not able to pay for what for their care there, and it's a real important piece. But I found it to be really mission driven there, and top to bottom. I've seen our front office gals. I saw one stay an hour late one night, getting a homeless patient a glucometer. She was a type 1 diabetic, and she was living in the shelter with her bottles of insulin. So you can imagine that might be a little scary without a glucometer. She's got to, dose her insulin, and so this one Vicky, she stayed an hour late one night just to get her glucose monitor, which was huge and real important. It was, put her out. She'd rather be home, but I really admired her for that. That was great. And I think it's delightful to work at the FQHC. Attracts people who are mission driven, I think. And if you look for people who are thinking that way, it's really it's a delight to practice with that mindset, with that group.
Wonderful, wonderful. And once again, we are so grateful to have Shasta Community Health Center, FQHCs like Shasta Community Health Center, that keep those ideals and the heart of medicine at the forefront. And wonderful learning from that experience. Dr. McMullin, I feel like we touched on the individual practices, combating burnout, maintaining ideals. We talked about at a more clinical clinic level, maintaining ideals. And now I want us to take even probably the broadest outlook on this and talk about our healthcare system as a whole. And that is that unfortunately our own healthcare system can't always be said to put equity and justice as its foremost ideals. That while FQHCs are among the places that will take in patients whoever walks through their door, regardless of ability to pay or insurance status, that can't be said for many, many clinics and many facets of our healthcare system. And it is often the case and it often feels that the business model and the ability to maximize profits is the modus operandi of our healthcare system and of many clinics, and then that seeps into many providers as well. And I would love to have your thoughts on having more of those FQHC ideals be more prominent in our healthcare system as a whole, and how maybe we could move in that direction. I know this is a large load of a question, but if there's anybody who we would trust to have some wisdom on it, it would be you, Dr. McMullin.
Umer flatters people. Umer's good at flattery. That's good. I don't know the solution to that. As I was in my private practice seeing patients who paid me, and that was what I was aware of. I was very much in favor of our insurance system. As I come to realize how many people that does not serve, how many people have a very hard time getting to a dentist, a 2-year wait to get to a dentist. I'm a little more enchanted with a system like Canada has, that's a central payer. I think we're missing out that we don't do that. Capitalism accomplishes, pure capitalism accomplishes a lot of things. It can be good for pricing and competition things, but I'm not sure of its place in this arena. This place, if only the most competitive get medical care, that's not really what medical care is about. If only the most competitive get dental care, that's not really what it should be about. So I really like the model. So an FQHC is a private entity. So Shasta Community Health Center, as other FQHCs and lookalikes, they're not run by the county. They're not run by the state or the feds. They're a private entity that provides efficiency and some nimbleness to that organization. But their funding is a federal stream, and that allows us to focus on healthcare. So to have it paid from a single payer, but come down to managers of that healthcare who are accountable, who have an element of sort of competitiveness and I will say capitalism in them. I think that's a nice marriage of allowing us to take care of everybody, but keep some efficiencies. A lot of opponents to socialized medicine, we'll call it, say, well, wow, if the federal government ran it all, what would that be like? The VA is kind of a bureaucratic place, and it is. And that's why I really like the idea of a single payer, but to an entity that has skin in the game, that's in the community, that wants to help their community, that can be mission driven. I think that's what I see in the FQHC. That's very helpful, and I think that's a great direction. That's very threatening to patients who live on private insurance. They don't understand that, and they think that that'll be threatening to their care. And it's very threatening to physicians who make a lot of money off of private insurance. But
yeah,
frankly,
just regarding, if I can jump in, I just have to probe a little bit on because you gave a really great story earlier about this patient who needed a glucometer, right? And what I'm noticing, some of the points you brought up, including that, healthcare, and the nature of healthcare is that, there's a collective nature to providing healthcare because everyone needs healthcare at one point or another. So there's a collective aspect, in addition to the business and like the competition between different players in the healthcare system to provide a service. But that example of the glucometer, I just think about the difference between like value and profit in terms of giving someone a glucometer is probably preventing all sorts of costs from being incurred, like admissions for DKA or complications of diabetes. And yet, I don't know if that translates accurately, because you're saying that, a lot of the services provided are at a cost. And so there's this value without the profit. How is that? Like, what are your thoughts on how did that happen? That doesn't seem to make very much sense.
That's really deep, Matt. Yeah, that's really interesting. I think when you plan a structure of healthcare, you really need to decide the funding streams and the identified quality markers will drive the work of in this case, the health center. Administrators particularly are very cognizant of funding. And when I shared this story of the front office gal staying late for an hour, I know that my administrators thought, oh, that's an hour of overtime. I know that went through their mind. It just did. That's how their chromosomes are. That's how their DNA works. But yeah, then we have the discussion. That's why there's such an important, I don't know if this goes to what you're talking about, but in any organization, you've got to have a really equitable balance between administrative and clinical. And you've got to have those voices in those arenas that do the planning, that do the goal setting, the structure creation, so that either one of them can kind of get carried away. If you have doctors purely just running the show, they might run it to the ground because it might not be profitable. They won't be able to pay the light bill. But if you have only administrators running it, they're going to come up with all sorts of efficient, great ideas that create inefficiencies that they didn't realize. So, one concept that I enjoy at our organization, and when I was hired as the CMO, our CEO said to me, "You come to represent the providers here. Never forget that. You are here to represent what's going on in the office downstairs, so that we have a balance of this." So I think having to pay for the deal is inevitable. You've got to make sure that it's funded and can work. That said, it should be collaborative. It should be group oriented. Cuba has an excellent primary care healthcare system. It's very, very organized. There's a physician in each neighborhood. When they don't have something that they can't solve, it goes up to the next one and so on. And that takes care of everybody. So anyway, there's a lot of things to think about, but I think that we've got a lot we can learn. And I don't think we'll ever escape the price tag. But we've got to make sure what we spend our time on is real, legitimate, and translates into as much healthcare for the group as possible. But also you've got to have some flexibility to account for the outliers that you didn't reach. And one of our doctors who does a lot of outreach in our clinic, Dr. Patton, has a lecture that I really liked this one. When you're flying over the Midwest in an airplane, if you look down, you'll see the farms, right? And they're all quadrants, they're squares of acreage, but they're all fed by an irrigating system that rotates around in a circle. So when you look down, you see these squares with circles in them. And the circles are the plants that got the water. And if they're all in a circle inside this square, well, it's great for everything inside that circle. That's what our healthcare system is doing currently, is it's great for probably 90% right there. But there's some corners of that field that are getting missed. And that's where, for instance, the homeless people live. They're outside that system and it's not reaching them. The irrigation system isn't reaching them. So structurally, we've got to have, it makes sense to have a system that reaches most, but then you've got to have something else that can stay after for the glucometer, or go under the bridge to find Joe, or find the others. And I think that's a compassionate mandate. I think that we're lost without that. That's essential.
Yeah, wow. So Dr. McMullin, on that note, the note of greater access to healthcare and sort of getting outside the 90% that is sort of easily accessing healthcare right now. I know you've mentioned, you've done a lot of medical outreach in local communities to people who don't have a house, and to people who live maybe between shelters or even outside facing harsh elements. And you've been recognized for this advocacy in Reading. And could you just tell us a little more about how did that start for you? What made caring for the homeless a focus of yours? And I guess if you don't mind sharing a little bit of commentary on what your next steps may be and future plans in that realm may be as well.
I didn't appreciate it until I saw it. So we had an RN in our organization who for 20 years or more has gotten physicians to go out and do outreach, which basically is a backpack with some medical supplies and some sandwiches. And you go out and you find the homeless in your community and you engage and just start having the conversation. And it sounds a little daunting, a little scary, but if you do it right with the right pieces in place, it's extremely rewarding. And for anyone listening in a community, I would encourage you to identify where your homeless live, get a helper like a nurse, and then find someone who can help you navigate that community, someone who's lived there or someone who knows people, and have them go with you. And you, the 3 or so of you, you go and you just open the door with sandwiches and sit down and have a talk and start listening. And after a few minutes of sincerity, then the medical issues start to come out. And this person has a rash, an abscess, they've got lice, they've got heart disease, they're having chest pain. I mean, there's everything we regularly treat is out there. But that setting is really third world medicine for the most part. It's there's no MRI under the bridge. There's no CAT scanner there. And these folks who have a preponderance of mental health disorders are really not good at making it to appointments inside the irrigator, inside the circle. So they are therefore left out in the corners. But I've encouraged my residents, when you find your community you're going to land in, and when you take a couple half days a month and get your sandwiches and your backpack and your helpers and go to your Skid Row and just start talking. And you'll find an abundance of what you went into medicine for, I think. In a hospital system where we're pushing people to stay inside the irrigation system, like do this, do that, those kind of rules, homeless people don't do well in hospitals. They don't do well in clinics because of all those things they have to do. And with all the bipolar stuff that's going on and all the attention deficit disorder stuff that's going on and schizophrenia, they just don't do well in those systems. So those of us who work in the systems begin to be impatient with them. And there's this antagonism that happens. But if you go to their home and sit down on a log, and I've always enjoyed hiking. And when he said, you want to go on a hike, we're going to go find some homeless people, I said, heck yeah, that's not in the office. Get me out of the office. That's great. So I enjoyed that immensely. I wish I could do more of it now. We did hire a full-time physician in our system doing that, and that's his entire goal is to do homeless outreach. That's why he went into med school. That's why he went into residency, and he does an outstanding job of that. It's fun to work with him. He's doing a great job, and he's got lots of great ideas for system work. One thing I love right now that we're working on is it's called a medical respite, and a respite in this sense is a place where a homeless person can go as they exit the acute care hospital. So if they go in for a trauma, cancer treatment or something like that, if they're going to exit, they're under the same hospitals under the same pressure of insurance regulations for them as anyone. So they want to get them out on day 3, not have extended hospital stays. But for homeless people, that's really doesn't work well because they don't have a place to go and heal. So a respite is a place that's basically just a place to stay. It could be motels, it could be a building, it could be scattered. And the health center's been very forward thinking about that, engaged the hospital for funding. And so basically we're currently running a 10 to 15 bed respite in motels. The hospital funded that up front. There's some early data that's very positive about what this has done for the hospital in terms of decreasing 30-day readmission rates, decreasing extended stays, decreasing unnecessary ER visits. That's some of the things that really can help with. And a respite's a piece of healthcare for the homeless that's very engaging and very exciting. There's a large organization called National Healthcare for the Homeless Conference, or NHCHC. And I would encourage anybody to look up their site. It's very robust. It's very full of this stuff. It's about, there's outreach, there's respite and everything. But
Dr. McMullin, this respite program, is it a recent program, or how were you involved in getting it off the ground, and how is it funded?
Sure. Yeah, they've been in the U.S. for several years. When you rotated with us, Matt, we didn't have this. It's typically funded by the hospitals. So you go to the hospital and you make a business and humanitarian case. And if you can be persuasive, you will save them. So we've shown our hospitals in our community the numbers that we predict we will save them 7 figures annually. And for that, we need about $200,000 from each of them. So hospitals, if you can get them in the game, that's usually who funds it initially. We're pretty happy to see that Medi-Cal, I know our carrier, Partnership Healthcare, this next year will be funding respites. So that's an exciting thing. It's going to save them money. It's $200 a day in a respite, where it's $3,000 a day in the hospital. So it's gotta pencil out for them. So it's a great idea. But we've been working on our hospitals for a long time. It's been like 5 to 7 years in coming. Just started to break the ice this last 2 years, and I think we've got some really good early data showing benefit to the hospital systems.
Dr. McMullin, just so I'm imagining, I'm hearing that some of the challenge to this work that you're doing involves the fact that patients who are homeless tend to be difficult patients. Patients who are homeless experience a certain level of stigma for whatever reason, probably when they're getting healthcare and in a lot of other settings. And and where I'm in residency in Salinas, we take care of a large population of migrant farm workers who may be homeless or between homes, and as well as facing structural barriers due to their immigration status, and just a lot of vulnerability. And I'm just curious if you have any comments about in advocating for these folks, navigating those stigmas in those conversations you may be having with hospital leadership or other stakeholders, and like how do you think about that, and how do you navigate that in your advocacy?
I think first of all, you need a vision of it yourself. So as you work with migrant workers, you come to know them and come to understand their story and their journey. And that one is particularly heartbreaking because that fills our grocery stores. And, all of us would complain if we didn't get our strawberries and our lettuce, right? But I mean, there's these people out there breaking their backs, working very, very hard to provide that. So to understand the story yourself first, or as far as the homeless go, that 70% are disabled, 90% easily don't want to be out there. They're just stuck. And then you've got to bring it into some narratives so that you can teach. There'll be people who are sympathetic to what you're talking about because of they've also learned about this. But you've got to be able to go to the Rotary Club and go to the Lions Club and go to your city council and make a case for this amongst people who don't understand it, who don't understand, and kind of just put a label on most everybody who's got less money, that they're lazy and that they're not working hard, and that we shouldn't enable them by helping them. To really fight against that is to teach who's out there and why they're there. And very important when you do this is the story. So you find, we talk about storytellers, but you've got to tell the story of this family who came to the United States because of the hurricane in the Honduras. They sat on their roof for 2 weeks. They lost everything. There's nothing there for them, and they're being preyed upon by the gangs and everybody else. If any of us experienced that, we would absolutely leave our country and go somewhere else. And so, when you can relate the story, then people can begin to relate and understand why you're advocating what you're advocating. And you've got to advocate. There's the public opinion piece, but there's also advocating with political people, and trying to get to know who your representatives are, what moves them, what's persuasive to them. Try to be involved in getting people elected who will be sensitive to the things that are important to you. All those layers of advocacy are really, really important and really exciting, sometimes very frustrating, but I think it's very exciting. Probably one of the funnest things I've done is go speak at the city council about homelessness, and try to shake up some of the paradigms that are there because people don't know. They just don't understand yet.
Amazing, Dr. McMullin. Dr. McMullin, I thought I would, you mentioned a few analogies. I thought I would expand a little bit. You mentioned the square and then the circle that gets the water within that squares and the corners missing out. I would add on to that even within that circle, that the further you are from the sprinkler, the less water you're getting. And so even those that are covered within the circle of water, the further out you are, the less resources or wealth you have, the less central you are to that sprinkler, the less access to healthcare you're getting.
Depends how good the sprinkler is and how good the pressure is, right?
Very true, very true, exactly, and that goes to systemic questions. But Dr. Right. Dr. McMullin, I just, you were talking about homeless advocacy, and this brought me to another question, that we often do not get a formal education in the history of our profession and its role in leading change to improve the living conditions outside of our clinic, which have been famously now coined the social determinants of health. In fact, that type of education is not just not taught many times, but even at times it has been ostracized, that physicians being outside of the clinic, being involved in advocacy on the social determinants of health has sometimes even been ostracized. And I thought I would get your thoughts on how do we reclaim the narrative of physicians and providers being, as Virchow famously said, natural attorneys of the poor, as leaders in improving the social conditions and the social determinants of health for our patients.
Yeah, So I don't think you're going to storm the Capitol and make it happen, right? But clearly, as a physician, I think have that mandate. You clearly have the charge to advocate for systems that, just like you would diligently take care of a patient on call at night, it's incumbent upon you to advocate in some fashion for the system that will take care of the disenfranchised, the patients. And if you don't see the disenfranchised, you're not looking. You're in the wrong place. You're in the middle of the circle, right? And that's why it's good to go out of that and go find people who are out in those other circles. I remember one student we had come on outreach with us, and we talked. Before we started, we said, okay, so the homeless, what's this about, and why are we helping them, and so on like that. And he made the comment. He says, well, they're not doing their part in society. They're not paying taxes and going to work and being responsible and things like that. And I thought, well, that's kind of a typical middle class narrative of someone who's living in the circle bubble, who hasn't seen what happened. And I said, so he's a very sincere individual, wants what's right and things. I said, so let's, at the end of the morning, you tell me what you think about that. After we visited several homeless camps and had talks with people, engaged people with obvious mental health issues, obvious disabilities, obvious things back there. And he said it was super eye-opening for him. And I think that's exactly what I learned was that there are people in situations who are just like me. They love their families, they want the best for life, for their kids and everything like that. And that's what really their wishes would be. But they're in a situation where they're unable to move things, or they're incompletely cared for. So I think we've seen examples of physicians. Our respite here was largely physician/administrator driven in those discussions. I think one of our physicians in training right now is one of his projects is to do an outreach to what he found was a migrant worker camp in our area. To initiate some of those projects, to start them and get them going. They can, if you're smart, they can really take off. You think big, start small, and start, doing incrementally, and then get other people involved as you go, other collaborative groups and individuals. Keep an eye out for people with common interests that you can collaborate with, and things can really grow and take off. So multiple places to advocate. I would say just go do it. I wouldn't spend a lot of time, wasting your breath with the senator and the president. There could be there's some mileage there too, but just go do it. Just get a backpack and go find your homeless people. Go get 4 of you in a van and get some medical stuff, and go set up a tent at the migrant worker camp, and start rendering care, and say, we'll be back every Friday evening. Get public health involved then, so you're bringing immunizations. Start gradually collecting your level of medical records. There's going to be prenatal care there, people who aren't getting prenatal care. There's going to be kids without shots. There's people with high blood pressure that's untreated. Diabetes is rampant, that's not even being attended to. So just go do it. And think big, start small. I had the privilege of working on a nonprofit that we started like 3 or 4 years ago. And, we started with Facebook donations and started putting people in the motel. And it was a small base, but that's grown to, I think next year that's going to be a $1 million or $2 million revenue per year nonprofit, which is super exciting.
Wow, Dr. McMullin. That was an excellent answer.
Good.
At this point, I'm coming off of 3 weeks of nights in the hospital and labor and delivery, and thankfully I'm going to have 2 weeks now on community medicine coming up, where maybe I'll have a little bit of time and bandwidth to maybe even think about doing some of these things you're recommending to us today. And so I really appreciate it. This has been such an enlightening conversation. And just sort of to wrap things up, I would like to invite, if you have any final advice or pearls that you would like to drop for to go after what you've already shared, which we really appreciate, for the next generation of physicians and providers, to find joy in medicine and to live up to those ideals of medicine.
Yeah. I think one thing that you hit on there is that there are times in our lives when we have variable amounts of bandwidth. And residency is one of those really busy times when you can't just do everything you want to do because you're very busy doing that thing. And that's okay, because that's the foundation for the rest of your medical practice is what you learn in those years. So to understand and remember that you've got different bandwidth at different times. One thing I think is important is envision your last day. Just envision your last, you're laying in your bed. Maybe you'll be 80, maybe you'll be 50, I don't know. But you'll be laying on that bed and, somebody's either there or maybe nobody's there. It's your last day here, and then you're going to be gone and moving on. And at that day, when you have that happen, what are you going to be glad you did? And what are you going to wish you did more of? And we often spend a lot of time and a lot of effort on things that day aren't going to matter very much. I worked 60 hours a week for 30 years. That's really not going to be a big carrier on the deathbed, right? It might be really important if you had people in your life that you were influential to, that you helped when they were down. If there was family there, if there were friends, if there were patients who felt that you made a difference in their life. But spend your time doing the things that you'll be glad you did on your day zero, or whatever we want to call it, day X, the last day of your journey here. And I think that as we kind of look down the road, that helps me kind of remain balanced and kind of refocus every day on what I'm going to focus on today and what's important. And mostly it's the people that you engage. It's the engaging them and helping them on their way and their journey. And if you do that, it's one by one. It's sometimes in groups, but it's mostly one by one. And if you make those engagements productive and positive and inspiring for people, they feel loved and cared for, whoever it is, and especially the groups that don't get that structurally. I think that's really key. So I think you guys have reflected a lot of that good direction in your lives. I know when you rotated with us, both of you, we've talked about things like this, and I think just keep it in mind. Just keep it up there. Don't get too disenchanted by the system and its faults. Just go do it. Go make something happen. And it's very exciting when that. So live your last day first.
Wonderful, wonderful. Wow, Dr. McMullin, I feel that, not just in this moment, you've uplifted my own spirits. I'm sure Matt feels the same, but also given us so much wonderful advice, thoughts, tips to maintain meaning in medicine, to live up to our ideals. And it has been such an honor having you. And you've been such a mentor to myself, to Matt, and to countless others. And I hope everybody who has a chance to view this video realize what a special honor and gift it is to have you, not only as a part of this interview series, but as an advisor, as a mentor, as a part of our lives. So on behalf of Ideals of Medicine, on all those watching, we wanted to say a very warm, heartfelt thank you for joining us and for all the work you do for the patient care, for the mentorship, and all of that. So thank you so much.
That's a pleasure to be here.
All right. Well, wrapping up the Ideals of Medicine interview. If you enjoyed this video, please like this video, subscribe to our channel, and consider supporting us on Patreon to fund this ongoing production.
All right. Take care.
Thank you.